My name is Martin Lee and I'm one of the Birmingham Orthopaedic registrars. Here is a presentation covering Dupuytren's disease, which is a thickening of the palmar fascia. As it does so, it draws the affected digit into a state of flexion. In the clinical photograph on the right here, you can see a pre-tendinous cord affecting the ring finger. You can see how the ring finger is forcibly dragged into flexion. It's worth noting that this is not a tendon. This is a cord, which is a thickened part of the fascia. The risk factors are summarized from A to H here, and it's worth noting that there is a strong genetic component to this in families. Interestingly, this is very much a disease affecting Vikings, as it's far commoner in Scandinavia and northern UK, and it's even been used as a marker of somebody's Viking heritage. In terms of symptomatology, this is a classically painless disease that may occasionally ache or itch. The main problems people report are an inability to fluidly perform activities of daily living, such as dressing oneself, washing oneself, and writing properly. Sometimes people cannot even actively extend their digits because the palmar fascia is that tight. In particularly aggressive forms of the disease, it can actually affect their plantar fascia as well, where it's termed Lederhose's disease, as well as the penis, and you may have come across Peyronie's disease in urology. The typical age range for the patient should be no fewer than about 50 to 60 years old. Anybody presenting in their 40s or earlier has a particularly aggressive form of the disease that should be monitored closely. Examining a patient with Dupuytren's requires you to look at both the hands simultaneously. Look very closely for any scars over the palm or over the palmar surface of the fingers, and look and even feel for the cords and the nodules which can be present over the MCPJs. You can ask the patient to try and actively flex and especially extend the digits. And a very useful test in primary care practice in the GP is to ask the patient to place their hand as flat as they can onto a table and see if there is any gap. This is termed the Houston's tabletop test. If there remains a gap despite the patient pressing down hard on the table, that is a relative indication to refer onto hand surgery for further intervention. From an investigations perspective, the history and examination are very much sufficient and normally no further investigation is warranted. In rare situations in the post-traumatic stage, for instance, if you're worried about a chronic PIPJ dislocation or a malunited fracture that can resemble Dupuytren's disease, you may wish to get an X-ray. Other possible differentials to consider here include trigger finger and extensor tendon injury as well. In the primary care practice, you may wish to work up for the disease associations with Dupuytren's, such as the LFTs for any hepatic issues, as well as any diabetes. Management can be divided into medical and surgical. A treatment option that's becoming increasingly popular both in the UK and in the US is to inject collagenase around these cords. What clinicians will do is inject what we call Xiaflex, which is a collagenase derived from Clostridium histolyticum, around the cords. The patient goes home, and the next day, once the enzyme has had time to work, is for us to stretch their finger out, and the patients do report a high level of satisfaction afterwards, especially because they can feel and hear their cord cracking and breaking up. And the recurrence rates for this are actually quite favourable. However, surgery does remain the gold standard, and there are a whole host of scars you can create depending on how many cords and how many digits are involved. However, the commonest forms of scar will involve some kind of zigzag, as this prevents any scar contracture in the palm. Here, in a fasciaectomy, what we do is we open the skin and remove all the diseased cords and fascia that can be involved, and usually we can primarily close the skin. However, in particularly severe conditions where the skin simply doesn't shut, overlying the cords and there's gaps, you may see in some patients a skin graft being used over the defect, and you can easily spot a skin graft because the skin colour and texture of the graft is usually significantly different from the surrounding palmar skin. Recurrence rates can be quite variable, but are generally as well quite favourable. So to summarise, Dupuytren's disease refers to thickening of the palmar fascia, and please be aware of the risk factors and disease associations for this, as these are common questions in the exam. Thank you.